Good morning. I'm Dr. Bill White, and I'm with the American Orthodontic Society, and I'm a general dentist, but I've done nothing but orthodontics for the last 42 years, and that includes some temporal mandibular joint work, which has to be done with the orthodontics. Uh, anyway, I'm going to talk to you this morning about guided eruption and space control. And we're able to do this by the reduction of deciduous teeth, and we able to reduce them by doing these pulpotomies, which I've shown you how to properly do them, and I've done many of these and have never had any problem with them. So anyway, let's get on into the deal this morning. This young man, and this is a unique case for me because this young man is my youngest son, and we did this guided eruption on him, and he's about 50 something years old now, so these pictures have been taken a long time. So anyway, let's get on with it. He is his teeth, deciduous teeth, were perfect. I mean, they just were lined up. Uh, I'll show you the models here in just a minute. Absolutely perfect. And so if your deciduous teeth are ideal like that, you're going to have a crowded problem because the permanent teeth are going to be bigger than the deciduous teeth. And sure enough, we did. Here are the pictures of just pictures of the models that we took, and there's no problem at all with them. I mean, they're perfect class 1. The height's good, everything's good on them, but from the cuspid to cuspid in here is going to be crowded because there's no space in between these deciduous teeth. So when we look down, this couldn't be any better in here. That's looks like almost perfect relationship there, and everything looks good. So, but when these teeth began to come out and the permanent ones come in, they just do not have room here. So we worked with these two, and then when the other two came in, we had to come in and reduce these deciduous cuspids. Of course, we did pulpotomies on them same time, and that came in ideal. Then we worked on guiding these other teeth into position right here. Now we've got another video we've just done on how we do these pulpotomies with this zinc oxide eugenol, just as thick and padded out to where we could pack it kind of like amalgam. Not quite as thick as amalgam, but we actually pack it down in the nerve canal with a amalgam plugger. So here's the problem, and this is where many parents will bring their children in when these lower when the deciduous teeth start to come out and the permanent teeth are coming in, and they're crowded or lapped over out of position, and they'll bring them in for you to see. And so here's where you could talk to them about doing this. Now these teeth came in, these two centrals, and they couldn't make it in, so they turned sideways, you see. Now, you can either reduce these, but you don't have to. You can just leave this thing alone till the next ones start in. And okay, here the laterals started in, and it's a lot worse now. And you got they're probably several millimeters lingual to where they should be, and the space is not adequate. So he's got problems with his upper teeth coming in too. They are kind of back behind in here. Not a big problem, but the lower ones are what we're concerned with right at this point. Now the distance these are behind here looks like about 3.5 millimeters or so. Now this one is not quite as far back, but it's at least three millimeters. Now by doling out this space and you have to do the pulpotomies on the teeth. The tongue actually presses against these teeth and shoves them right up into place, and the lip pressure out here catches the teeth. Now he's functioning properly. He doesn't breathe through his mouth. He's not a tongue thruster or thumb sucker or anything. If you've got kids with problems, then you have to kind of control the problems, but you can guide the teeth in on people with problems in class 2s or class 3s or whatever you want to, and get them doing it. So we use this in a lot of cases, not in the whole thing, like normally we reduce these and then reduce this tooth back here and let the cuspid and first bite come in, and then the second bite comes in under the portion that's left here. But in his case, it went so smooth that these teeth just came out on their own. You can see as we get into the video, and just a little further. Now we took tissue out on him, or just took the Bard Parker and trimmed that up after I infiltrated down here and got this good numb. We took some tissue out and reduced this and packed the zinc oxide eugenol down in the root canals, and we show that in the other video if you look at it. Now these teeth will just move up into place. They don't just move up, the tongue shoves them up in there. All right. Now this is a few, I don't know exactly how much time, but just a few weeks or a few days really, these teeth began to straighten out like this. Now we've got a reduction of this diastema. It's going to do it on its own. I did at one time. I trimmed a lot, took the ligament out, tried to get these to come together. Most of them you can just leave them alone, and as the permanent laterals come in and as your cuspids come in, it'll just shove these upper centrals together right there. No big deal, but his do that. Now we will have to come in up above and get room for these laterals so they can come through. Now this lined up, and look how neat this worked out right here. We trim these cuspids. Now the nerve is gone in them. If you have any problem, you can trim it out or work on it. Now I like to kind of shape these up and take the sharp edges off, you know, and this is really neat. And you can get these teeth lined up. Now I don't think that this would just happen automatically, but we just kind of helped nature. If I'm assuming that I can help nature, you gotta be in order. You got somebody that's functioning normal, and their mouth pressures put these teeth where they really ought to be. And so I hope you'll learn how to do this and don't be draw back on the deal of taking the nerve out of these. I've done thousands of them. And on each patient, you would do about four. I mean, you do four in front, and then you come back here and do four more on the second deciduous molar. And so that's 8 on each patient. So you end up doing a lot of this. Now, he's doing all right. It's a little later down the line, maybe a year or so. Time passes in here, so this is best done by children do these children by somebody that's working on children all the time. The pediatric dentist really should do this. The orthodontists don't seem to want to do it or don't like to do it. It just never caught on because I've been doing this for ever since 1970 when I did this in a table clinic and showed how you could actually bring the teeth in without doing putting orthodontic appliances in. And won this clinic and had to speak on that for a half day. And so that's when I first started lecturing. And so I've been doing this for years and years and have done many of these teeth and have never had any problem with any of them blowing up. So that's a good thing. There's a few pediatric dentists that are doing this, and I've lectured on it all over the country and many places in the world. So now we're putting it out everywhere through these videos. And here's Mark again, and that's his name. Now the upper laterals came in, they really look screwy. You see, I guess this is being pushed by the cuspid, but it's way off in there. Now the diastema's closed a little bit, and this is coming in. We'll take this tooth down and give it room and let it come over in this, and we'll reduce this one also. Let's see. All right. Like that, we're going to see that the other lateral is out of place too. And our lower anterior is staying like it was. Okay, we come in and take these off, about a half of them, and you just taper it off down there on the root, you see. And the actual root of this deciduous tooth is up in here, and you just kind of come off to the side. As this lateral comes in, it moves over in there. You take this down where the lateral is. It's better that you see the lateral so you can see it in here. When you're cutting this or reducing it, you can see it. You don't want to even touch it. Just stay away from it. Give it a little space in there. Now let's see what happens. Well, this is I don't have any time on the first deal here, I don't think. But this is 2 of 75, and you can see where these laterals have been pushed by the tongue and the proper swallowing and pressure, and these are lining up pretty good right in here. Okay, now the tongue pressure guided those into place, and now we're just watching the case, you see, and when something needs to be done, we'll go in and do it. That lateral slipped over here, and the pressure of the tongue on the lingual side of this and the lip out here kind of rotated as these two laterals right here and brought them in. This is darn good orthodontics. You just don't use anything, you don't put anything on there. So if you're doing this, you have to charge something of it to keep in business and everything. You have to charge too. But look how neat this has come in. The midline is dead center. They line up good. But I've had a hard time over the years getting this just didn't catch on like wildfire, and everybody started doing it. They're kind of afraid of the pulpotomy, I assume, but it's really good. And the deciduous teeth came out back here. I didn't have to do the second phase of this, what I call a slicing technique. It's not slicing. We use a carbide burr, a long shank carbide burr to do the reduction. It's a new one right off. It's sterile and everything. Okay, you can see everything's coming in now. This tooth will just go automatically. We didn't have to take it out. Normally you would have to do that to get the cuspid and the first bite in place good. Now you'll see the permanent cuspids will come in place. They'll come down. Now the lip's going to press that and pushes it over. This won't come over very far. This one will. Right here, it'll come over and line up with the rest of the teeth. And there it is later, and he's up a little older now. And the cuspids are going to push in some. And you see this one's coming in, the lips and the pressure out here is tucking these teeth in. This is just helping the natural development in here. I don't think there's any way this would have come in ideal like this, like it is, without doing this help. Now those teeth will erupt on up in there, and here it is 79, see. So several years are going by. We're not doing anything though, except guiding, directing this in the mouth, and he's functioning completely correct here. And now this doesn't get any better. You couldn't treat this case and put the teeth in this position. He's never worn one thing in the mouth other than just this reduction, and the teeth have come in now, and has no retainer or anything. This is where the pressures in the mouth are putting these teeth, and that's where they ought to be regardless of what anybody's. I'll bet you they're further forward than a Tweed diagnosis, and so they'd want to bring them back in. and that's the way they look. So uh, I'm going to recommend that you learn how to do these pulpotomies if you don't do them already, and we use them frequently in many other areas where we can reduce these deciduous teeth with no problems, and that works out great. So I'm gonna, let's see, find the last one here. Oh, I wanted to show some people wonder about doing this, packing this zinc oxide and eugenol in these deciduous teeth. They want to come in and put some type of filling over this, or maybe crown it, or do some kind of mesh. You don't need to do one thing to this tooth. Now, if it had a cavity in it, you could clean it out or put something in it to fill it up or something, because you may have to keep it for 2 or 3 years even before you lose these deciduous teeth in the back. Now, we took this one out on somebody, and the resorptive process of the bicuspid coming up in here, the bigger bicuspid just ate and see, it went in front. It didn't eat the zinc oxide and eugenol. It just ate the dentin out and just left a little shell of enamel on there. And I broke it over here, took it out. That's been in the mouth now at least a couple of years or so. And you look at where we drilled in here and went down this horn and down the other horn and packed the zinc oxide eugenol in there real hard. Packed a little more and then smoothed it off out here. And that's all you need to do to these teeth. And they'll come out like that. That's zinc oxide eugenol. And I chipped the enamel, pull it out. The enamel just a little thin layer. You get a nice view of that. And as this bicuspid comes in, the bicuspid will kind of hug this area right in here and come up, and that'll kind of fit into that position. Now, the deciduous tooth, usually the roots go out kind of something like this, They're sprawled out, may not be exactly that way, but as this tooth comes up, it eats the root off here, but then it comes to this enamel, and it's got to, where we've taken it off here. But as the tooth comes up in here, it'll just move over and set inside here, and now your cuspid can come in up in this area, see. Now this is saved for the second bicuspid, and it will come right into this area right here, push this tooth out and comes right in and sets right in this portion, and now your 6-year molar will come in this part. And you can guide these teeth in by reducing these deciduous teeth. It's amazing. I've treated a lot of them, and many of them don't have to have any orthodontics done later on. I mean, any braces or anything, but some of them need a few things, kind of like a serial extraction. But I've had people, I had one mother, I think I told you about in one deal, where when she was a little girl, she didn't like this when I was doing it. She wasn't that bad about it, but she married and went off to some other town not too far away, and she had a little girl, and her child had crowded teeth, and she brought her all the way back for me to do this procedure. Said I didn't have to wear braces, and I want you to do this to my daughter, so she won't have to have them. So anyway, I think this is the end of this video, and I'm gonna try to stop it here. And I appreciate you watching, and I hope you're able to use this procedure. Just in doing these pulpotomies, you do not have to get the blood out of here. You just go up and cut that out with a round burr, that you just come in here, and then you pack this zinc oxide, even with an amalgam plugger. It's pack it in there, smooth it off, or pack it and then add a little more, smooth it off, and just leave it alone. It's fine, just like that. I'll come up and smooth out any jagged edges of that, and from then on you don't have to worry about it. You can, if the tooth does decay, you can fill it or do something. It has no sensation to it whatsoever. Okay, I'm gonna tend to close this out. I think this is the last picture that we've got, and I'll say goodbye, and I hope you get to watch it. Thank you.